Live. Good morning, ladies and gentlemen, dear participants. We are happy to see you all this Saturday morning. We are going to continue our conference. It's the second day of the conference. First of all, I would like to thank our sponsors. Without their support, our conference could not be possible. First of all, General Novartis, Yokas, Charity for Med, and other sponsors. Association of Hospice Help, Palliative Care for Children, and Genetic Center. Thank you for your support. It's really helpful for us to carry out our educational events. Today, we continue the discussion started yesterday. We talked about medical therapy and treating adults. But today, we are going to talk about multidisciplinary approach. We will see how the healthcare changes for patients with SMA with multidisciplinary approach. Treat patients, not disease. Our first guest, Laurent Servais. Then we will have the speaker from Great Britain. Patient standard of care of patients with SMA and what has changed for our patients in terms of standard of care. I give you the floor, Laurent.
Thank you very much. Really appreciate. I'm going to try to share my screen. Can you see my screen? Okay, it's in presentation mode, right? So first of all, I'm super happy to be with you today. And I would like so much to be face-to-face with you. So I have a deal with Olga. She did not tell you, but I have a deal with her. I accepted to give this lecture remotely, but next year I need to come and I need to visit Moscow, especially with my daughter, because we learn Russian together, but we're absolute beginner so far. So at the bare minimum, it allows me to understand the title in Russian of my talk. So my name is Laurent Servais. Indeed, I have the chance to work in 2 countries, in the UK and in Belgium. And actually, it helps to understand that sometimes standard of care can be very different from one to another country. I've got a couple of disclosures. I'm not going to take a lot of time to speak about that. Just make a screenshot if you wish, and then read it when you have time. The first thing I want to emphasize that spinal muscular atrophy, the primary manifestation is simple. This weakening of voluntary muscle, okay? But the experience of patients is actually dominated by downstream complications. Like, for instance, compromised respiration, impaired nutrition, deformity, and limited functional ability. And when we consider the follow-up of patients, we need to always consider this different aspect: nutrition, respiration, rehabilitation, global management of our patients. So as you probably know, there are standard of care that have been published in 2007 and 2018, and they emphasize a very important concept, the concept of multidisciplinary team. You just cannot, even if you are the best doctor in the world, you just cannot treat yourself alone in the middle of nowhere a patient with spinal muscular atrophy. You need others. You need a pulmonary doctor. You need orthopedic. You need palliative care. You need geneticist. You need a speech therapist. You need a physiotherapist. All these different HCP need to work together with the patients in the middle. And of course, this is highly dependent according to the different types of SMA. And of course, the more the patient is disabled, the earliest is the SMA, the hugest is the need in terms of the different HCP. And this is true across the life. I used to say to my patients, when we discuss about the disease or when I announce the disease, you have 100,000 genes that work perfectly well. And that make you a human being with all the experiences of a human being from birth to death. And there is a single one that is deleted, which means that, yeah, we need to pay attention to the disease, to the treatment of the disease, to the management of the disease. But we need to consider that this is in the context of a human being with the full experience of a human being. And it starts with genetic counseling at birth, because of course, parents may wish to consider having another kid. And during this lecture, I will emphasize how disease-modifying treatments are actually modifying our standard of care and our understanding of the patient's follow-up. Now that we have treatment, genetic counseling becomes more difficult, because 10 years ago, when a patient had SMA type 1, you could be, in most of the time, very clear on the fact that there is 1 out of 4 chances to have another kid with spinal muscular atrophy. But nowadays, the parent will ask you the question, but should we take this risk and treat at birth? And this is an open question. And this will, of course, depend if we're talking about SMA type 1, about SMA type 2, about SMA type 3, or about very early form. So genetic counseling has become even more difficult with new treatments, because now we have another option. And then comes the problem of the school orientation. These patients in many countries, believe it or not, but go to school with other kids with disability. And this is something I'm strongly advocating against. I think that patients with SMA should go in the school with other children for many reasons. The first one is that they're clever, so there is no reason that they will go in a school with disabled children, because we know that there are very few schools with just motor deficit. Specialized schools are most of the time open to all kinds of deficits. But these patients are clever. But more importantly, it's not so much the SMA patients who need the society. It is the society who need the SMA patients. If patients in the wheelchair go to normal school with normal children, and that we explain to children that we need to make some adaptation in the school, in our way of functioning, because we have a person with a disability, and we want this person with a disability to be with us, to learn with us, to progress with us, we will help the society to be better and to be more open to the people with disability. So, at the contrary, if we have a school where we send our patients with disability, the other will grow without even knowing that they exist. And if they exist, they need to be in a special school, in a special part, but not integrated in the group. So I think that bringing these patients at schools and in the activities of the other patients is important for them, but it's also important for the society, and to teach us collectively how we need to be inclusive with the people with disability. The next thing to consider, of course, is that with the treatments, we have now patients who have SMA type 1 who survive, and these patients are potentially quite weak and subject to infections. right? And this will be always a balance between the risk of infection and the risk of living in a bubble without social contact. And that's where the care, the pulmonary care, will take a lot of importance, because we need to get these patients prepared to go to school and to meet the virus and the microbes of the schools. But if we keep them at home without social contact or with few social contact, then it's a big loss of opportunity for them. Next thing is also to consider, and believe it or not, we don't think about that, especially for all the children when they are 40, 50 kilo. How do they go to the loo at school? How do they go to the restroom? And you know, sometimes we even don't think about that. But I can tell you that I have several patients who have constipations, who could have kidney stone just because they don't drink, because they are afraid to go to the loo, because there is no process to help them. So this is something to consider. It's quite easy when you are 5 or 6 years old. It's much more difficult when you are 40, 50 kilo, and when you have a spinal fusion. So this is really something that is really, you know, pragmatic, but that we need to fix, to consider when we consider the school orientation, and to show you that we need to drink. I'll drink my coffee now. By the way, this is a SMA cup. I advise you for a SMA cup. House adaptation, of course, these patients, when they survive and they live in the wheelchair, will need house adaptation. And again, the treatments bring more questions than answer, because 10 years ago, it was quite clear the trajectory of the patients in terms of longevity, in terms of functional ability. But now we have many more possible trajectory in these patients. So to plan the house adaptation has become even more challenging. Transition to adulthood is a very important question. And we used to work as pediatrician. We, the pediatrician, we have a small stethoscope, we have our teddy bear in our pocket. And we needed at one point to accept that our adult patients have adult needs and possible also adult comorbidity that are better managed with by an adult neurologist. I've thought a lot about this problem of transition, and I can tell you that there are several good systems, but there is no good system without good people. The most important is definitely the collaboration between the pediatric and the adult. And in our center of Liège, for instance, we have a very smooth transition. It takes some consultation. And sometimes the patient themselves, they say, well, would it be, now we have a difficult decision to make. Could we ask Professor Servais to come in the consultation and to be part of the discussion also. So it's something very smooth, and the patients have the opportunity to ask to see the pediatrician again, especially when they have difficult decision to make. Sexuality. Well, I use to propose my patients when they are 15 years old to get what I call a moment together, which means that I kick the parents out of the consultation. And I started introducing the concept quite early at life. When the patient is 12 years old, I used to tell the parents, well, get ready, because in 3 years, I will kick you out of the consultation. And the parents, they understand, because they have some time to think about that. I can tell you that there is no patient who does not dream about being married, having a girlfriend, being in a romantic relationship, and they all have the expectation of teenagers, classical teenagers. The problem is that it's much more difficult for them. It's not impossible by far, but it's more difficult, and there are questions that come, and it's not easy to find the answer for them. It's even more difficult to ask the answer, to have the answer that they don't know how to ask the question. So it's important for you as a doctor sometimes to be proactive. And what I used to say is that, well, as you know, I'm getting old, right? And older and older. So my patients who were like 6 or 10 years old, 10 years ago, now they are 16, 17 years old. And I learned from them. And I will tell you some of questions that my patients may ask when they are 16 or 17 years old. Maybe that's not a question that you ask for yourself, but that's the kind of questions that my other patients ask. Like, for instance, is it possible to have a baby when you have spinal muscular atrophy? Is it possible to get married when you have a spinal muscular? And then you look at the patient and say, oh, yeah, good point. Is it possible to? So help them, bring the questions. Of course, it's not during this first consultation without the parents. During this first consultation, I used to tell them, well, it's important for me to get this time together where we can have open discussion. And do you have any topics that you would like to discuss without your parents? And then, of course, they don't, right? And then I say, well, okay, it's okay. So we can speak about football. But just to give you an example, you could have questions about sexuality, for instance, and that's maybe the right moment to discuss that. Probably you don't, right? But let's imagine that in the coming weeks and months, you have some. Do not hesitate to bring it back, because I have some patients, for instance, with SMA, who ask me if it's possible to have sexual intercourse when you have spinal muscular atrophy, right? So you just bring the questions. You just bring the possibility. You open the window. You open a window of opportunity. And if you do, you will see that your patients will be very grateful and that you will be able to help them. Nearly all our patients go on the internet, on websites to get married, to meet someone, to meet the right one. They don't go on internet to meet someone to have rapid sexual intercourse. It may happen for type 3, but they go on the internet to meet the right one. And then they are vulnerable because you maybe know or not that on the internet, you have people who have a specialty of catching this kind of people. And I had 2 patients who told me the following story. They went on the internet, they met a fantastic girl, and she was from Ivory Coast or Nigeria, and she's beautiful, and she has not an easy life, right? She is a little bit exploited by her family, and she has a daughter, and nobody helps her. And so she doesn't care about disability because she took care of her mother who was also a disability. And this discussion can happen for months, not for days, for months. And during this discussion that has nothing to do with sex, they have a very nice and lovely discussion. And each exchange is a real plus, is a real added to the quality of life of the patient. And he looks forward the message. And it can happen for weeks, for months. And then all of a sudden the girl disappears. And it is just terrible for them. She disappears for like 1 week or 10 days. And then she reappears and says, oh, I'm sorry, I had a problem, I had an issue. My computer is broken, I don't have the money to repair it. But don't worry, I'm working hard, I will get the money, and I can still write you from the internet cafe, but it's, 3 hours by car of my village. So, but as soon as it's repaired, I will write you again every day as we did before. And then the immediate answer is, how can I help you? How much does it cost to repair this bloody computer? And then they start paying. And they start paying for the computer. They start paying for the grandmother who is sick. They start paying for the issue that the family has, and because of this issue, she could get very serious problem. And of course, this is not a girl who is behind the screen. It's a group of men who are very specialized in catching people with vulnerability. So we need to discuss with that, to discuss about that with our patients. We need to explain what may happen. We need to tell them what are the risks and what are the beautiful sides, the shining line of meeting on internet. And we have several patients who have met on internet, but what are the risks? And I can tell you that this is not easy. And then they will maybe themselves want to get a baby, and genetic counseling will happen again. And then one day you will have to discuss palliative care with these patients, and it may happen at any age, as you probably know. And in Belgium, probably not in Russia, but in Belgium, patients with a terrible and degenerative disease may ask for euthanasia. And Belgium also is very specific because even children and teenagers may ask for euthanasia, which is very difficult to discuss. To be honest, it never happened with patients with spinal muscular atrophy. Could happen, but it's never happened. It happened to me several, especially with patients with ALS. It happened to me with patients with limb girdle muscular dystrophy. It happened to me for patients with myotonic dystrophy, but it never happened for patients with SMA so far, crossing fingers. So just these different examples to explain you that to manage a patient, to consider a patient, goes far beyond prescribing a drug, checking the nutrition, checking the pulmonary function. It's also to consider this patient as a human being with the full experience of a human being. And that if we are perfect doctor prescribing the right drug, taking care of the lung, taking care of all the medical aspects, but we don't pay attention to the strong need of our patients for their affective life, for the fact that they are just racked on internet by a band of bloody bandits. We could get with a patient who is doing very bad, who can sometimes get suicide, and I had a patient who suicide in such a context, which is of course terrible. So you've done your job perfectly, but you have not understood that your patient is actually a human being with all the experiences that are impacted by the disease. All these experiences that are impacted by the disease, and that you need from your patients to learn how you can help them and what they are. So our neuromuscular centers can be organized different types. I used to say there are centers that are organized with individual consultations, and then there is a team meeting. So it's like, in a church with different little place where you go to the geneticist, then you go to the pneumologist, then you go to the orthopedist independently, or you can have a kind of multidisciplinary consultation with, of course, in the middle, the child neurologist, but then the physiotherapist, the pneumologist, the orthopedist, and all together see the patient all together. They are different models. I must say that I prefer the one on the left because that's the one we use in Liège. Because definitely it helps to have a very face-to-face discussion with your patients. And then you have the adult and the children. You have two different models. For instance, our Belgian models is our center is for adults and children, and it's the same team and to a certain extent the same doctors, and we transition smoothly. And you have another model which is more typically French, with a pediatrics department, and everything is very pediatrics, and all of a sudden the patients go to the adults, and this is a complete different story with different doctors, and there is no way to go back. I must say that I prefer the one on the left because from a patient's perspective, it makes transition much, much easier. The only risk of this model is to continue to follow your patient as a pediatrician. And either you've thought about that and you're ready to change, either you have good adult neurologists who are happy to help you. So the way we are organized is that you have a pediatric coordinator and an adult coordinator. One of them is the coordinator, and today in our center, it's the adult one. And then we have, of course, we rely on all the specialists from the hospital, who then could be adults or children practitioners. And we have a team of paramedic with social assistant, nurse, physiotherapist, nutritionist, psychologist, neuropsychologist, speech therapist, occupational therapist, who are common for all the patients, which means that the physiotherapist will be the same physiotherapist across life. And I can tell you this is very helpful. So the commitment in our centers is to see the patients at least once per year. But as you might imagine, a patient with SMA once per year is not enough. We used to see our patients with SMA type 1 like every 3 months and the other every 6 months. We need to discuss the patients at least once per year during a team meeting. And I think that it's extremely important to have a formal discussion, even if, let's imagine it's type 3 doing perfectly well, does not need anything. That's fine. You can have a rapid discussion. It is okay. That's fine. But just take a formal time for that. If we want to be paid by the state, they need to meet the non-MD healthcare professional during 1 hour. We have a commitment to follow standard of care, to enter patients into database, and to report on patients' evolution. So the trajectory of a patient, most of the time what happens is that the parents connect with me or with a secretary and say, well, I want to get an opinion. And then we organize the meeting, and then I said, wow, this patient has a neuromuscular disease, and I need the opinion of the physiotherapist, the surgeon, and the cardiologist, for instance. So I prescribe my workup, and then we have a meeting with all these people, we discuss the patients, and then the coordinator will tell the patients, okay, let's meet again, and let's try to put together the different tests and opinion we've done. And this, of course, will circle every 6 months. So let's consider, for instance, how will new treatments interfere with standard of care. And I'll give you some examples so far, right? Like genetic counseling. Let's consider a patient identified by newborn screening. And I know that in Moscow, you have a newborn screening program ongoing in some maternity, and that Dr. Vlodovets had the opportunity to include several patients into the rainbow fish trial. So this little gentleman is a patient who has been identified by newborn screening, and he was lucky he could be treated at day 41. The same very patient 1 year later, look at him, is doing perfectly well. So what are the questions that I will ask to myself when I see this very patient? The first one is he or she completely normal? If I examine this patient and I benchmark these patients with my global understanding of what is the normal development, does this patient fit with normal development? So which is a completely different mindset than to say, well, is he improving? Is he doing better? When it comes to pre-symptomatic patients, the question is more, is he or she completely normal? And my objective, my reasonable expectation is not that these patients take 4 points or 5 points on the shopping tent. I want these patients to be within normal range. And if not, then I could ask the question. The second question I could ask myself is there some kinds of bulbar issue? This, for instance, we know that patients who have been included in the nurture trial with nusinersen, 20% of them presented with mild bulbar signs, even if they were ambulant, which is completely new, right? Because when I was a baby myologist 10 years ago, patients who were ambulant were not supposed to have bulbar issue, right? Bulbar issues were for non-ambulant patients. And nowadays, with patients who have been treated before the symptoms, this is a question that you must ask yourself. Another question that I will ask myself, especially for our patients who has been treated by gene therapy, and like this little gentleman, if this patient has been treated early and gets a normal trajectory, my question is there a moment where the transgene could not be expressed anymore? And if so, then the trajectory of my patients will change. And this is an important concept, because you could imagine that this patient was not treated at 41 days, but later on. And at this time, you could save a very significant number of motor neurons, but not all by far. And these patients could have symptoms at first, but keep improving. And the question is, when your patient has a clear deficit, is this deficit related to the fact that when you had to act, it was already a little bit too late, and you could save whatever you could, but nevertheless, there is still a deficit that you have not, a pool of motor neurons that for which you could not do anything. And then the other question is, or did I save all the motor neurons because I act very early, but now my transgene is not expressed anymore? So we need really to look at our patients with a much longitudinal perspective that takes into consideration the possible evolution of the disease, the growth of the patients, and the dynamic of the drug that we give, which makes our life more complicated. We need to be very aware of treatment side effects and the temporality of these side effects. We know, for instance, that liver issues with gene therapy happens in the very first days after the treatment, but not years after the treatment. We can be more careful about very long-term side effects when you give on a very frequent basis the drug. So the treatment side effect is something that we will discover. We will discover with time. So we need to be very cautious, and especially about emerging phenotype. As I told you as an example, we have now these patients who are ambulant, but with a bulbar issue, right? I'm pretty sure that in 10 years, we'll see some phenotypes of SMA patients that we are never not aware today that it exists. If you want, for instance, an example in another disease, please consider Pompe disease. Patients with Pompe, with congenital Pompe disease, they used to die before, and now we treat them, we keep them alive, and some of them may have bulbar issues, deafness, mild intellectual disability. I'm not saying that it's what we're going to observe in patients with spinal muscular atrophy, but we need to keep our mind open when we follow these patients, and to try to figure out if there is not something abnormal or something that is different of what we know that happens in these patients. Let's consider now a patient who has not been screened and treated by spinal muscular atrophy. Look at this lovely little princess. She's a typical type 1, right? With the only distal upper limb movement, no facial involvement. So the question I will ask myself during the follow-up is, what about immunization and vaccination? And in many countries, the doctors refuse to vaccinate, to immunize. It is, of course, completely stupid to use super expensive cutting-edge treatment and then not to vaccinate these patients and not to immunize them against VRS, right? And to lose in a pulmonary infection everything that you could save with your treatment. Growth will be extremely important to be follow-up. And again, I will not try to get something, a weight that is perfectly normal. I would like to get just a weight that increases progressively. Again, especially if the patient has been treated with gene therapy, I will ask the question, is my patient's trajectories always on the same track, on the same beaten track? I'll, of course, have a look at treatment side effects. I will be aware of possible emerging phenotypes, and again, I will be very proactive. And being proactive is a key in the follow-up and the treatment in the patients, not only with spinal muscular atrophy, but neuromuscular disease. You need to think ahead before the disease does something. You need to have thought about it before, and to have initiated the action before the disease does it for you. So, for instance, in this little princess, I know that she has, we cannot see it because of the beautiful jacket, but she has a small chest. She has a paradoxal breathing. If I start a treatment, I would start with early non-invasive ventilation, even if she does not formally need it. And that's what happened with time. She could acquire the sitting position. The very last video I have of her is this one. She's doing quite well. She's not ambulant, but she's an happy kid. Again, during the follow-up immunization, bone health, God knows that we're not attentive enough. We do not pay enough attention to that, and we should, because if you have an ambulant patient and he breaks his leg, you can lose all of a sudden the benefit of the treatment. So let's be very careful about bone health. Respiratory management is super important in the first years of life. In my treated patients, it seems to be better with the years, but I need to be cautious, and we don't have enough follow-up. Of course, treatment side effect, we need to be aware of possibility with the time. Education, we spoke about school, psychomotor evolution. I must say that in our patients who are what the symptoms very early, and we start treating in the first months of life, but they were already symptomatic. I'm a little bit concerned sometimes about psychomotor evolution. And on top of that, we probably need also to work on parental education, because this experience of having a child who has a very severe disability, who could die, you invest a lot, you go sometimes abroad, you go for new medicine, and this child who has been told he will die, survive, but with a lot of care, and he becomes the center of the family. You can imagine that the dynamic between the parents and the children will be very different of a normal dynamic, and this child will become a kind of little king or little queen. And sometimes a king or queen can become a tyrant, right? A tyrant, and we need to be very careful about that, and sometimes give some guidance. Orthopedic management is something that again needs to be proactive, and rehabilitation. So personal consideration about these patients, the price of disease modifying treatment is huge. Without standard of care, this money is just wasted. There is no disease modifying treatment that works outside standard of care. Gene therapy is a fantastic option, but sometimes we do not sell it properly. And I know that some patients, after having discussed with the doctor, have the impression that one dose and that's it, and the patient is treated, is cured, and there is nothing else to do. This is not true, not true. It's fantastic to have the options to treat the patients with gene therapy, but nevertheless, they need standard of care and they need follow-up. And it's not because there is not a prescription every day that the patients do not need to be followed up by a multidisciplinary team. As you know, there are plenty of patients who have been treated by the lottery or crowdfunding, but crowdfunding or lottery never includes standard of care coverage. And so when I meet a patient who has crowdfunded and wish to be injected, I always say, well, okay, fine, we inject, and then we're going to pay for the wheelchair, for the non-invasive ventilation, and for all the standard of care. So again, it comes from the misunderstanding that one shot and that's it. In standard of care, it's a lifetime plan. It's not a one shot. It's something that we need to organize and to consider on a 60 years period of time. So we initiated a program that is called Standard of Care for All. This is the specialists who have been involved, including from Ukraine, from Russia with Dr. Vlodovets. We had the resources for patients, and as you can see, there is a lovely Russian lady here called Germanenko. Together we try to put something together to have not only explanation about SMA disease landscape, but acute care and emergency service, orthopedic management and positioning, respiratory care, nutrition and swallowing, physical rehabilitation, primary care physicians and patients caregivers. So we try to give an online resources that was available at first in 5 pilot countries, and believe it or not, but Russia is one of these pilot countries. It's a collaborative program created by a broad spectrum of healthcare professionals. If you go back to this list of people, Max is an adult intensivist. Lisa is a physiotherapist. Susanna is a pneumologist, rehabilitation myologist. Charlotte is a physiotherapist. Georgia also. Myself, I don't know exactly who I am. So, you know, there are several specialties that have been involved in this program. This is a repository of resources and educational material. It is free of charge. So should you wish to train and to use this as a resources for you, for your team, please just tell me. We will explain you how to work with that. And I am myself working on that with writing case studies, interactive case studies for this program. So that's the list of modules that includes. Each module takes about 1 hour, 90 minutes to be followed up. This was funded by a grant of Roche, and so the access to the platform is can be provided by your rare condition partners of Roche. And there are also resources for patients who have been provided by Olka and her team. So the conclusion of this long lecture is that standard of care has never been so important. Never. We have the chance to be able to treat these patients. We have the chance to change the course of the disease, but we will never be successful if we don't apply very good standard of care. We just waste the time, the money, and the hope of the patients. It needs to come with the treatments and this standard of care. There are several opportunities available to improve, to train. I gave you this example of standard of care for all. Don't forget that there is a society, international society, that is called the World Muscle Society, in which there are plenty of opportunities for learning, for interacting, and where we have a very inclusive policy for people from all over the world. I know very well the secretary, the general secretary of this association. It's me. So if you wish to join, even if you have limited resources, just tell us. We'll be more than happy to be very inclusive for students, for all possible stage of the career. And the main point is, consider when you treat a patient with spinal muscular atrophy and with any neuromuscular disease, the main point is play like Kasparov. What I mean like that is that if you are not a good chess player like me, you will just play in order to what you see on the table. But if you play like Kasparov, you will play acting for the future. You will try to move ahead the move of your opponent. And you will consider what's going to happen in 2, in 3, in 4 next stages. And that makes a good chess player, and that makes a good myologist. Consider non-invasive ventilation because before your patients really need it. Consider bone health before the fracture. Consider discussing sexuality and adult life with your patient before it gets bullied and harassed and racked by bloody bandits on the internet. Consider the possibility of emerging phenotype. Consider the possibility of pain. Consider the possibility of having difficulties in swallowing before the patients get the pneumonia because of the aspiration. Always play one strike ahead of the disease, or two or three, because maybe now when you will think about a patient with SMA, I wish you'll play like Kasparov. Thank you very much for your attention. I'm sorry for this very long lecture, but I will be more than happy now to take your questions.